Hello, everyone. On behalf of the Amyloidosis Support Groups, also known as the ASG, I want to welcome everyone to our CAA webinar. The ASG has been hosting a private CAA patient group on Facebook for more than 10 years, and we've seen it grow to more than 1,000 members representing many countries. This webinar represents a collaboration between the ASG and the CAA researchers and clinicians who comprise the International CAA Association. Although we will be discussing some investigative treatments and trials and might even have representatives from the pharmas sponsoring these investigative treatments in attendance, I do want to emphasize that the idea of having this webinar and the agenda of topics that we will be covering was conceived in its entirety by the International CAA Association, working with the ASG and without any input from any pharma. Also joining us today from the ASG is our Executive Director, Paula Schmidt. Paula?
Good morning, everyone. Thank you.
And our Special Projects Director, Bob Gibson, who's our acting IT man today. Bob?
Good morning, everybody. Let me make a few comments. One, we're going to be posting the video of this onto our ASG website. It should be available within 2 weeks. So look for that. It's on YouTube at Amyloidosis Support Groups. If you search for that, you should be able to find the site. And secondly, at the end of this webinar, there will be a post-webinar survey. It should pop up on your screen when you close out Zoom or close out the meeting. Please fill that out and give us your feedback. We really value that and will be particularly useful for the panelists in the CAA here today.
Yes, thank you for mentioning the survey. That is so important. And that's how we develop these webinars. We see what you liked, what you didn't like. It's really important that we have your input on these surveys as well. Also, the questions, there's a Q&A box on your screen, and we hope to get to as many questions as possible today. So when you type them in, they won't be answered right away. We will answer them verbally at the end of today's webinar. Some of you have emailed some in, and we will cover those as well. The chat is not active right now, so you can't type anything in the chat. If you have a question, be sure and type it in the Q&A section, okay? And if you have to leave early for any reason, that survey will pop up and you can answer it then. Okay, next we will hear from Dr. Eric Smith from the University of Calgary, Canada. Dr. Smith?
Thank you, Muriel, for the introduction. And I'm here representing the International CAA Association. I'm the chair of the association. I'm a neurologist in Calgary, Alberta, Canada. Thanks to the Amyloidosis Support Group for hosting this webinar. Having 1,000 people on a Facebook group, I mean, that's amazing. So thanks for all the work that the ASG has done in the past for CAA. The International CAA Association is a collaboration between clinicians, scientists, and people with lived experience with CAA to improve clinical care and find better solutions and treatments for CAA. I'd like to also introduce the vice chair of the association, Dr. Susanne Veluw, who will tell us a little bit about our plans for engaging patients and people with lived experience at the CAA Association. Thank you, Susanne.
Thank you so much, Eric, and thank you to the Amyloidosis Support Groups for hosting this webinar. So my name is Susanne van Veluw. I'm a PhD scientist based out of Boston in the US, and as the co-chair of the International CAA Association, I'm also really involved with thinking about the next steps in the life of our association. We just celebrated our 10-year anniversary, and looking ahead sort of to the next 5 and 10 years, we're really hoping to emphasize our patient engagement efforts and our outreach. And so one of the things we've been thinking about is starting a patient advisory council. And so we'll be looking for volunteers to join us for that purpose. So please be on the lookout for more. I'd like to hand back the word to Muriel to introduce the speakers in today's webinar.
Thank you so much, Susanne. Well, first, we will hear a general overview of CAA from Dr. Stephen Greenberg from Mass General. So, Dr. Greenberg, are you here?
Yes, I am. Thank you, Muriel. Are people hearing me?
We can hear you and we can see you.
Okay, the joys of Zoom. Anyway, it's a pleasure to be here, and thanks very much to everybody for joining, and thanks to the ASG for allowing us to put together this webinar on CAA. So I'm going to share my screen, and hopefully all my technical glitches are done for the day. I think everybody can see the screen. Okay, so I'm going to provide a general overview, and people on the call who are my patients have probably heard me say about 92% of what I'll say in the overview, because it's very similar to conversations that I have with patients as they're diagnosed with cerebral amyloid angiopathy. First, give you warm greetings from Boston for people who are not from the Northeast or not from the U.S. at all. You may not recognize everything in here, the Boston Marathon, the Red Sox back in better days, and our beautiful New England seasons. So this will be my overview for the next few minutes, and just again, really broad questions, and really the same questions that I discuss with my patients in the office. So what is CAA? How does it affect the brain? How do we diagnose it? And how do we treat it? So starting with the what is CAA, and I always tell people, when you go to medical school or any healthcare training, it's like learning a foreign language, because there's so many terms that become second nature to us, but are not really normal words in the English language. So cerebral amyloid angiopathy, CAA, and each word kind of makes sense. So cerebral meaning it's in the brain. Amyloid, well, of course, I'm speaking to the amyloid support group, so people are familiar with the broad range of amyloids. But for our purposes, this is a substance. These are a range of substances that are made by the body itself. In the case of cerebral amyloid angiopathy, it's made by the brain itself, and it's sticky, and it's stuffed to deposits. And then the angio part means in the walls of blood vessels, just like an angiogram is a test of the blood vessels. Showing at the bottom different grades of that amyloid sticking in blood vessels of the brain, and people in the field are very used to looking at these kinds of images taken from brain tissue, typically at autopsy. Sometimes people will have a biopsy of tissue during life. And so, and the brown is a stain that turns deposits brown if they have that amyloid in them. So you see the very mildest brown staining. If you look at that panel D in the lower left, that's just a little trace of the brown in what's a blood vessel that's you're seeing sort of in cross section. So imagine the blood going in the middle of that tube. And then on the right, you see now more widespread brown. And then in the right, really, the whole wall has been replaced with the brown amyloid. And I'll come back to this a little bit as we talk about what CAA does to the blood vessels. But this is sort of our starting point for what cerebral amyloid angiopathy is. I mentioned that the amyloid is produced by the brain itself, and most of us think it's a garbage product. I think the majority view in the field is that this amyloid, it's made from a larger precursor protein, but that amyloid itself doesn't have a function that has been clearly defined. And so we're very happy when it breaks down or exits the brain. And one of the ways that it drains out of the brain is along the outside of blood vessels. And this is a lot of work, including people who are on this call, who have shown this drainage pathway. And it can be a normal drainage pathway along the walls of the blood vessels, but it's also probably the way that the amyloid gets access to the vessel walls and becomes that deposit in the walls of the blood vessels. And of course, the way that people are often most familiar with amyloid is as part of the Alzheimer's disease process, because basically that same garbage product can also deposit in the brain itself and cause Alzheimer's disease. And we won't talk, or I won't talk that much about Alzheimer's disease in this talk. The two of them clearly, the two diseases, CAA and Alzheimer's disease, are clearly related to each other. They both share that common amyloid. They also have differences, and the majority of our CAA patients are not diagnosed with Alzheimer's disease. The majority of Alzheimer's patients are not diagnosed with CAA. although the two certainly can coexist and coexist more than by chance alone. So that's the what is CAA. How does it affect the brain? And the way that we as stroke neurologists see it most manifestly in the brain is when it causes these bleeding strokes. So there's a CAT scan in the upper right, and the white part is the blood, is the bleed, and it's something that a neurologist can see from across the room. CAT scans are very good at showing recent bleeding in the brain, and we think that the bleeding happens because that after the amyloid builds up in the walls of the blood vessels, it makes them leaky in some way and allows them to bleed. There can be large areas of bleeding or micro bleeds, and we'll talk a little bit more about that when we get to the diagnosis of CAA. So that's the most dramatic way that amyloid angiopathy can show up. Another way that's a little less dramatic, but is also definitely impactful to the brain, is that it's kind of non-bleeding brain injury, and it comes under a broad term of small vessel disease. So CAA is not the only small vessel disease in the brain, but it's one of the major ones. We think two main varieties, and CAA is one of them. And what you're seeing in the lower right, again, it's that those tubes are always blood vessels. And this is a blood vessel that's basically lost all of its normal elements. Blood vessels are kind of amazing things. They're living, breathing tissue. They're not just pipes like the plumbing in your house, but they have the ability to open wider or to close down depending on the needs of the brain. And when they're not working correctly, and we're not 100% sure what that means, you get other non-bleeding kinds of injuries. An example being these white patchy areas on the MRI scan that we're showing on the left. And we think that that's the main way in which CAA causes its own worsening of cognition, of thinking and memory, and the kinds of things that we ask everyone asks their brain to do every day. And what you see, these are data from our colleagues at Rush University in Chicago, who have looked at a lot of brains at autopsy and look at the way people's cognition changes over time. And what they showed is controlling for all the other kinds of pathologies in the brain, like Alzheimer's pathology. The worse your CAA, the more rapidly you tend to go downhill over the years before dying and having an autopsy. So CAA is not the main driver of why people lose their memory as they get older, but it's a contributor. And we think that often when people lose their memory as they get older, it's not just one thing, it's a combination of things. And CAA is one of those slices of the pie. And then I'll mention one other thing in terms of how CAA affects the brain, that people can get these kind of episodic symptoms. And we think that that's often caused by small areas of bleeding, as shown in the MRI scan at the bottom, that happen to be in places of the brain that control the strength in one arm or one leg, or the sensation in one arm or one leg. And we think that the blood products set up a kind of an electrical reaction to the blood products that then can create these temporary symptoms. And for us as neurologists, that can be really challenging because they seem like they're a TIA or a warning of a stroke. In fact, they're not, and we don't want to treat them the same way we treat somebody who is having kind of the classical form of TIA. So these are three main ways that we recognize CAA, that it comes to attention to us in the medical system. And then it raises the question, all right, somebody comes in, how do we diagnose it? So that the only way to know for sure that somebody has CAA is to look at the brain blood vessels under a microscope, either at autopsy or, as I say, sometimes at biopsy. Well, of course, most people who come to us don't have biopsies, and we want to be able to diagnose them during life. So the Boston criteria that have gone through several iterations over the years allow what we call a probable diagnosis that is really driven by the MRI appearance of the bleeding lesions, or in some cases, some of the non-bleeding lesions, that give us, I'm using this term, positive predictive value, meaning that if one of us applies the Boston criteria and says, yes, we think you have probable CAA, that there's a greater than 90% chance that, in fact, if we were able to look at the blood vessels under a microscope, we would say that yes, they really do show advanced CAA. So, and these are the different forms that those MRI appearances can take to meet the Boston criteria for probable CAA. So bleeds in the brain, and this is a really common way that we make the diagnosis is by seeing multiple larger or smaller areas of bleeding. And I always tell my patients the M in MRI stands for magnetic, and the blood has iron in it, which means that MRI is amazingly sensitive at picking up even microscopic deposits of iron, microscopic bleeds or micro bleeds in the brain, as well as larger areas of bleeding. So that one in the lower left is a common way we diagnose it. Another increasingly common way is by bleeds that are not actually in the brain, but on the surface of the brain. And I kind of mentioned those before as the kind of bleeding that sometimes will set off these temporary episodes of neurologic symptoms, but it's also a way we can diagnose CAA. And most recently, we are now using some of the non-bleeding markers, and I won't go through these in detail except to say that there are other ways that we can get clues and to make the diagnosis of probable CAA using non-bleeding markers as well as the bleeding markers. So how do we treat CAA? And the starting point is, and also the finishing point is, we don't have what we want yet. We don't have a way to knock the amyloid out of the blood vessels and restore them to health. You'll hear about what is on the horizon in terms of research studies, but where we are now. So one very common question that comes up is about anti-clotting medicines or blood thinners. And I'm showing a scale because for some people, they have no reason to be on a blood thinner, and so there's no discussion that you have to have. But for other people who do have a good reason to be on a blood thinner, it becomes a very careful balancing of risks and benefits in both directions, and that's can be a complicated discussion. There's no absolute rule that says this person absolutely can't be on blood thinners, this person absolutely has to be on blood thinners. It's really weighing out the two sides of the scale. I'll say to my patients often, I feel like we're steering a ship and there's a big rock on one side and a big rock on the other side, and we want to steer the ship right down the middle so that we miss both the rocks and don't have any kind of stroke going forward. A second thing, this one's an easier decision, which is treating high blood pressure. And we don't think that we don't believe in making the blood pressure go lower than normal, but we do believe in really adhering to the guidelines. And for the majority of people in per US guidelines, that means having your blood pressures in the 120s over 70s or lower. And for the most part, there's a still uncertainty in the field, but we think that lower tends to be better unless you're becoming lightheaded when you stand up. So in general, we try to be sticklers for following the existing guidelines for lower blood pressure. And we think that's not only good for CAA, but also good for your heart and good for preventing other kinds of strokes as well. Avoiding heavy alcohol use, there's some evidence that's not airtight, but enough evidence that heavy alcohol use increases the bleeding risk. And so that's something that we advise our patients not to do. There are a bunch of what I call gray zone medicines, in particular the statins and some of the depression medicines. And this is a longer discussion because the evidence isn't clear cut. There's some evidence that the statin medicines or some depression medicines can increase bleeding risk. The evidence is not clear cut, and the benefits of these medicines are clear cut. For many people, they're clearly required. So that's another kind of weighing of risks and benefits with a lot of uncertainty. And then in general, I recommend what I use the term a heart healthy diet and lifestyle. And here I'm referring to the American Heart Association. There's certainly other guidelines that are out there for diet and lifestyle. We don't know that these have any specific relationship to CAA, but we do believe that that they're what's in general, what's good for the heart is good for the brain. And so these are my general guidelines. And I also make a point of saying that otherwise there aren't restrictions on people, and questions often come up. Can I work out? Can I travel? Can I engage in sex? Are these safe things to do? And as far as we know, there aren't other lifestyle restrictions besides the kind of general guidelines for a healthy lifestyle. And even knowing all those things, we're still not in a good situation. I mean, patients, of course, always who've had a bleeding stroke and are diagnosed with probable cerebral amyloid angiopathy always say, well, what's going to happen in the future? And what I tell them is that there's a really wide range of how people do, that we have some patients who have one bleeding stroke and then another and do very badly. We have other patients who have one, maybe two, and then we follow them for year after year after year and nothing happens. And when you sort of add everybody up, you come up with numbers like this. This is a kind of curve we use in medical publications where it shows over years, and this is work that came out of an Austrian group working with others in the UK to look at people with cerebral amyloid angiopathy versus other kinds of causes of bleeding strokes. And you see that unfortunately, the CAA line towers over the other ones. And if you do the numbers, it comes out to something like 8 to 10% likelihood of a new hemorrhage each year. And that's clearly different from patient to patient. That's an average over many patients. And there are ways that we can look at an individual and try to be more accurate and say, well, yours looks lower than that number, or potentially yours looks higher than that number. But no matter how you look at it, that's still a high number. And so I'll conclude here just to summarize what I've said. So what is CAA? So it's an accumulation of sticky amyloid in the brain's blood vessels. It affects the brain by causing bleeding strokes or that kind of small vessel disease that we mostly diagnose it using criteria like the Boston criteria to make a diagnosis of probable CAA, and that there are steps that we can take, and we take in our office every day to lower someone's risk for future bleeding, but we're not where we need to be. There's still what I'm calling a really big unmet need for a disease-modifying treatment that will either substantially slow or stop the disease from progressing, and to make that 8 to 10% number go way down, and that's our goal in the field. You'll be hearing more, I think, in the next talk about the conference just concluded, our biannual International CAA Association conference in Munich, and I'll just lead into that maybe by saying that there's really an international coalition of investigators, clinicians who are dedicated to coming up with treatments that will fill that unmet need. So thanks very much for your attention.
Thank you so much, Dr. Greenberg, and you're going to stick around, and I know you'll be here for the Q&A as well. So that's really great. And next we will hear from Gargi Banerjee. Dr. Banerjee will give us a recap of the 9th International CAA Association Conference. So take it away, Dr. Banerjee.
Great. So I will just share my screen. So I hope you can all see that. Good afternoon, everyone. My name is Dr. Gargi Banerjee, and I'm based in London at UCL and also at the National Hospital for Neurology and Neurosurgery. It's really nice to connect.
It's not in presentation mode right now.
Ah, okay. Let me go back. Any better?
That's good.
Great. Okay. Sorry for the little technical hiccup there, but it's great to be able to connect with everybody. And thanks so much for everyone joining the webinar. So my task today is to share a little bit about the recent conference, the International CAA conference that we had. And what I hope to do in this short talk is just say a little bit about the International CAA conference, just the basics about, not only when and where the conference is held, but who turns up and what it is that we're trying to achieve. And then I want to go through some of the key highlights and key themes that emerged during the conference itself. Now, one of the things that was a big topic of discussion in the conference was the topic of potential new treatments. And that's something that I'm not going to talk about because I know that Mariel's going to talk about that later on. So that's going to be an important admission, but there's still a lot of interesting science to touch on. And then I will leave with some final thoughts. So you will have seen from the title slide that this is the 9th International CAA conference, and this is really just to say that there have been 8 others. So the conference happens every 2 years, and is really just a wonderful opportunity for people who have an interest in CAA to come together to discuss the progress that they've made since we last met. This year, the conference was held in Munich in Germany, and we're very lucky to be hosted in the Cardinal Wendell House, which was just an amazing venue for us to all meet. And so the conference was in mid-October. We just missed the Oktoberfest, but we still had a wonderful time, and it was really well attended. So just shy of 200 participants, and we really had, I would say, international representation. So these are flags from just some of the countries from which participants came to the conference. And I wanted to say a little bit more about the who turns up to these conferences, because this is one of the real strengths of the meeting, I think. So it's a real interdisciplinary meeting, which means that there are people from different backgrounds who turn up. So first of all, we have scientists, and again, this is a very broad term. So these are scientists, some of whom are working with patient samples. We've got scientists who work with model systems that aim to understand some of the mechanisms that underlie CAA, and also scientists who work on some of the technical aspects of brain imaging, so things like MRI scans and how we can understand those better. And then in addition to the scientists, we also have clinicians. So again, I'm using this as a very kind of broad term. And yes, that includes doctors, but also other healthcare professionals, such as clinical psychologists and others, who are involved in kind of day-to-day care and working with patients who have CAA. And then the final really important group are patients with CAA and their advocates. We're really lucky that there's a patient community that join us for the conference. And I have to mention here that the Dutch CAA Foundation, which is a patient-led organization that's really have supported the conference for many years and provide really great inputs into the meeting and really wonderful contributions to the discussions that we have. And I'll say a bit more about Dutch CAA later on in the talk. So I've talked about the when and the where, and I've said a bit about the why. Sorry, it's now time for me to say a bit about the why. And I think, when we talk about the goals of this conference and the reasons for the meeting, I think the short answer is that there are a number of really kind of fundamental and basic questions about CAA that we don't have answers to. These are the questions that we get asked in clinic. And really the goal of the conference, I think, is to bring people together who have expertise in CAA to try and tackle some of these questions. So examples of some of these questions are, why does CAA happen in the first place? We've already heard a little bit about the fact that CAA shares a protein with Alzheimer's disease. What exactly is the interaction between these two conditions? Of course, the question about new treatments is a really important one. But also, how do we make sure that we're providing the best care for people who are living with CAA? And so these are all questions that are really important and kind of drive the agenda of the conference each time that we meet together. So I think I've provided a bit of an introduction about the conference itself and why it's there and why it exists and what its goals are. And so what I'd like to do now is just go on a bit of a whistle-stop tour through some of the science that was discussed on this occasion. And as I said, these are really just the highlights. It's impossible to cover it all, but I wanted to give a flavour of the sorts of things that were discussed. So I think one of the key themes to talk about is this concept of brain waste clearance, and we've already heard a little bit about that from Dr. Greenberg. So we know that the brain makes lots of materials, including lots of proteins, and we also know that actually we probably don't want to keep hold of all of those, and some of those are going to be regarded as waste products, and the brain needs to get rid of them. And one of the things that we've found out, and there's been huge progress in this particular field in recent years, is the fact that blood vessels seem to be quite important in terms of how the brain gets rid of its waste. And so we talk about something called perivascular clearance, the idea that your blood vessels are surrounded by channels, and these are important for getting rid of waste. But there are also these newer waste clearance systems in the brain, something called the glymphatic system and the meningeal lymphatics, all of which seem to play a role in this brain waste clearance. And so there's a lot of interest at the moment about whether, if something goes wrong with that clearance system, if you're not able to get rid of your waste, is that what causes these proteins to build up in your blood vessels? And is this what causes CAA? And so this was a really hot topic at the conference, and people are looking at this in all sorts of different ways, but particularly by looking at model systems to try and work out exactly what's happening at a sort of cellular, molecular basis. but also looking at this from an imaging perspective. So are there things we can do with brain scans to try and look at these processes in people in life? So this was a really important theme, I think. So the second theme, I think, relates to inflammation. So inflammation might be a term you're familiar with. We know it's part of the body's normal response if you sustain an injury or have an infection. But we also know that inflammation can sometimes not be a good thing. So it can be harmful, particularly if you've got too much inflammation or you've got inflammation in the wrong place. And we know that there are disorders that result in inflammation in the brain. And so when we think about inflammation in the brain, and particularly when we think it's being harmful, we sometimes think about which cells are involved. So that can be often cells of the immune system. But also, apart from cells, that we know there are a lot of other factors that are important for immunity and are important for inflammation. So things such as antibodies. And so again, there was a lot of discussion at the meeting and a lot of presentations on the role of inflammation and potential immune damage in CAA. And the question of, which cells are the ones that are faulty and are responsible for this harmful inflammation, and are there other immune factors at play? And the other big topic that sort of was discussed was the fact that there are sort of newly licensed medications for Alzheimer's disease. And we know that in some people, they seem to cause inflammation in CAA. And so there was discussion about how this all ties in, how this all ties into CAA and the inflammation that might occur. So again, another key theme. So the third kind of broad theme I would mention relates to kind of rare types of CAA. So most people who have CAA have what's sometimes called a kind of sporadic form. So what that means is that we don't understand why somebody has CAA. It seems to be happening out of the blue or at random, and we don't have a defined cause. But we know that there are some very rare types of CAA where the cause is actually known, and we know what has caused CAA in that person. And so one example of that is Dutch type CAA, and I mentioned that the Dutch CAA Foundation because it was set up by somebody who had Dutch type CAA. Dutch type CAA is rare, and it's a form of CAA that's inherited, runs in families, and people who have this type of CAA have a change in one of the genes that's important for making amyloid, so a gene called APP. So this is one of the rare types of CAA that was discussed at the meeting. And the other type of CAA, again, is incredibly rare. It's something called iatrogenic CAA. So this is CAA that's happened many decades after medical procedures, most of which are not practiced anymore. But the reason to kind of talk about these rare types of CAA is that although they're much less common, they do tell us important things. So we've learnt, particularly from Dutch type CAA, a huge amount about the early stages of CAA and how those changes change with time. And they give scientists important insights into the biology of what is going on in CAA. And I think particularly for the Dutch type CAA, the Dutch CAA Foundation, and they've got a very, very active group, and they've been incredibly generous with their time, and it's led to some really important steps forward in our understanding of what happens in CAA, and much of that is relevant for the more common form of CAA that we see. So the next key theme to mention is diagnostics. So we've heard a little bit about that already, and as we've heard, imaging or brain scans are really important for diagnosing CAA. And for the most part, that's MRI scans, but there's also some work starting to look at whether we can use CT scans to diagnose CAA. And that's important, particularly for settings where perhaps MRI is not as widely available, and people are perhaps not being diagnosed because they're just not having the right scans. But then, in addition to that, we're always looking for new markers that tell us about CAA, and not only whether someone has CAA, but also what it might mean for them in the future with regard to prognosis, and also how those markers change with time. We often think of these things as being quite static, but there's a sense that actually some of these changes might be a bit more dynamic. I think the other important message from the diagnostics point of view relates to blood, and what I mean by that is, could we find a blood test for CAA? Obviously, that would have a lot of implications, particularly if people are not able to have brain scans for whatever reasons. And again, to go back to the Alzheimer's field, we know that there have been huge leaps made forward in terms of the technology in Alzheimer's disease and in terms of developing blood tests for the condition. And there's a question about whether some of those markers might also be relevant for CAA and whether we can borrow some of that technology in terms of making the CAA diagnosis. So again, this was another hot topic. And then the final theme, I've called it guidelines, but it's probably a bit broader than that. So, we know that if somebody has CAA, it's probably not going to be their only diagnosis. They may well have other medical conditions or other factors in their lives that need considering. And so one of the big themes that is a topic of discussion for every conference is about how to manage all of those things together with the CAA. And so we've heard a bit about high blood pressure and how important it is to have good blood pressure management in CAA. And we also know about a particular medical condition called atrial fibrillation, which is a condition where people have an irregular heartbeat. The reason that we think about this in the context of CAA is because the treatment, or one of the treatments for atrial fibrillation, is treatment with blood thinning drugs, so the medications that might make you more prone to bleeding. And of course, if you have CAA, then it's a real balance, as we've heard, as to whether what the relevant risk and benefits are of those treatments. So this was a topic of discussion, and I think one of the sort of allied and aligned things with that is the idea that sometimes these questions are really difficult. They're difficult for specialists to answer, and if you're in a setting where if there isn't a specialist, it can be really difficult. And so one of the key kind of aims of the association is to develop some new guidelines. And the idea there is that we can share our expertise with centres that perhaps have less experience with CAA. And it's really about the key things in CAA. So, making the diagnosis, thinking about medications that increase bleeding, but also other medications, how to manage blood pressure, and also how to think about CAA related information. So the idea there is to make some of these guidelines widely available, so that if there's a clinician who's perhaps less familiar, they have a resource that they can look at. So I'm coming to the end. So in terms of my final thoughts, so a highly successful conference, and I've spoken about some of the scientific updates and scientific topics that were discussed. But of course, what I've not talked about is all those other interactions that happen outside of those scientific sessions. And it's those conversations and collaborations that often drive forward the research and the progress that we need in CAA. And I think, also I just wanted to highlight that as a community, I think we're taking a lot of important steps forward in terms of understanding more about why CAA happens, getting better at diagnostics, thinking about the new treatments, which we'll hear about shortly, and also kind of developing resources and sharing our expertise so that we can ensure that as many people get the best CAA care that they can, regardless of where they are. So you've seen this photograph already, but I'll share it again. It's from the last day of the conference. So I'll just say thank you for your attention. And yes, I'm looking forward to some questions later on in the final session. Thank you.
Thank you so much, Dr. Banerjee. I didn't mention that you were from University College London, so I do want to get that plug in there for you, okay?
Thanks.
And now we're going to hear something that I know everyone's very eager to hear, about ongoing studies in CAA, and we're going to hear from Dr. Mariel Kozberg. So Dr. Kozberg, take it away.
Thank you, Muriel, for the introduction. And so I'm really happy to be here today to get a chance to talk to you a little bit about ongoing research studies in CAA, and really to try to focus in on potential treatments that are on the horizon for this disease. So as has been discussed a bit already, there are a number of steps that we think about in terms of leading to CAA deposition and later term kind of bleeding in the brain. And I know that Steve and Gargi both went through this, but I think it's important to start to think about where we could intervene and where interventions might be effective. So what we know is that amyloid precursor protein is first produced in the brain. That's then cleaved through a number of steps to form soluble amyloid beta, which moves around throughout the tissue of the brain. That then is cleared through a number of mechanisms, including along the blood vessels, so sort of in this perivascular space. And we think that during this clearance process, some of that gets seeded along those blood vessels, forming CAA. And then later on, after that CAA accumulates, that then leads to blood vessel damage and bleeding in the brain. And we can also think about all of these different steps as different places where we could potentially treat CAA to prevent these issues that we think about in the disease. So we can think about decreasing production. We can think about removing that soluble amyloid beta that's moving around throughout the brain. Think about improving the clearance to kind of get that out of the brain more quickly. Removing CAA and amyloid beta plaques from the brain, or actually decreasing the blood vessel damage that's caused by the amyloid beta accumulation around the blood vessels. So one thing that's got a lot of attention recently, and I know that I get a lot of questions from my patients about as well, is these anti-amyloid immunotherapies and whether those can be effective for CAA. So we know that anti-amyloid immunotherapies can, depending on the specific antibody, can either remove soluble amyloid beta or a number of different amyloid beta species down to amyloid beta plaques as well as CAA themselves. So can we use anti-amyloid immunotherapies for CAA? So as was mentioned, there are now two anti-amyloid immunotherapies that are approved for the use of use in the treatment of early Alzheimer's disease. And that includes lecanemab or Leqembi and donanemab or Kisunla. And these are monoclonal antibodies that actively remove amyloid beta from the brain. But they have been associated in some patients with severe side effects, and those are called amyloid-related imaging abnormalities, or ARIA. And there's two main forms of ARIA. So one over here on the left is ARIA-E for edema. So you can see this swelling in the brain. And then over on the right is ARIA-H for hemorrhage. And that causes things like bleeding in the brain. So microbleeds you can see here, but it can also lead to superficial siderosis and larger bleeds in the brain. So kind of a CAA-like presentation. And what we know now is that CAA is a really important risk factor for ARIA. And it also might be part of what actually causes ARIA. So some of those patients who are experiencing these side effects might actually have more CAA, or that's a part of why they're developing that condition. And there's two main parts to this. So first of all, antibody-mediated breakdown of amyloid beta, so sort of breaking down the amyloid beta that's in the tissue of the brains of these patients with Alzheimer's disease, might increase trafficking to the perivascular space, so kind of increase the amount of amyloid beta that's right around those blood vessels. Additionally, the antibodies might actually affect the blood vessel walls and kind of break down amyloid beta within those blood vessel walls, that CAA disease, and that could actually cause blood-brain barrier breakdown and edema and hemorrhage from these blood vessels. There's data from a number of different studies to support this. So this is an older data, an earlier form of anti-amyloid immunotherapy, showing that removing amyloid beta plaques from the brain, so those plaques we think about in Alzheimer's disease, might actually increase amyloid beta around the blood vessels, so what we think of as CAA. And so in this study, you can look here, this is an example of the tissue of a brain of a patient with Alzheimer's disease who didn't receive any treatment. You can see these plaques within the tissue of the brain. Now, this is a patient who received 4 months of treatment. So you can see this CAA surrounding some of the blood vessels in the brain. This patient here received 20 months of treatment. You can see very little plaques within the brain, but mostly still this CAA around the blood vessels. And if you quantify this across a number of different patients, comparing patients with Alzheimer's and those who received treatment, you can see in black is the amyloid beta within the tissue of the brain, so those Alzheimer's plaques. You can see that decreases with treatment, but the vascular amyloid beta actually increases. So the CAA is increasing with the treatment with these therapies. Additionally, this is some really recent work looking at whether the anti-amyloid antibodies bind to CAA and whether that leads to blood vessel damage and inflammation. And so this is over on the left, a mouse study looking at giving anti-amyloid antibodies to mice with CAA. And they found that when they gave those antibodies were located in the same areas where they saw the amyloid beta around the blood vessels, and that led to inflammation. So here, over here, this is a blood vessel you can imagine here. And then this is the amyloid beta surrounding that blood vessel. This is the antibodies right next to it. So right in that same area. And then over here on the right is the inflammatory cells right in that same region. Over on the right is a case report from a patient who received anti-amyloid antibodies and then developed, unfortunately, severe ARIA-E, so that edema. and passed away. And so this is an example of one of the blood vessels in her brain. You can see that there was a lot of inflammation specifically surrounding the blood vessel. And these were CAA affected blood vessels, and that's hemorrhage surrounding that vessel. Additionally, we know that more than just causing kind of bleeding and edema, the vascular function as well might be impaired with using these anti-amyloid immunotherapies. So there was a prior study. There was a phase 2 study of a monoclonal antibody called ponesimab, specifically in patients with CAA. And the idea was to see whether cerebrovascular reactivity, so a marker of vascular function, actually improved after giving these patients this antibody. And unfortunately, instead of improving vascular reactivity, it actually decreased vascular reactivity. So these are the patients here who received ponesimab. So they did worse in terms of vasoreactivity than the placebo. And so for all of these reasons, it seems that at this current stage, these anti-amyloid immunotherapies are not really helpful, unfortunately, for patients with CAA and might actually be harmful in terms of causing more of these side effects or damaging the blood vessels more. But there's a lot of other places where we can think about potentially intervening in CAA. And so I want to first look at this end of the spectrum of decreasing blood vessel damage. So trying to kind of prevent that later stage bleeding that we know happens after CAA accumulates around a blood vessel. And so this is some work from our group as well as a number of other groups that have shown that there are a number of sort of steps that lead to bleeding in an individual blood vessel with CAA. It seems that, initially you have a very healthy blood vessel. This is just, and then you start to have some amyloid beta surrounding that. That leads to some leakage from that blood vessel, some issues with the blood-brain barrier that can later trigger inflammation to surround those blood vessels. And that inflammation can then potentially damage those blood vessels, leading to further vessel damage. And so one very interesting approach to try to prevent this process is to use this older antibiotics. This is minocycline, which is an approved antibiotic, but in addition to being an antibiotic, it also has some additional actions where it's able to actually decrease inflammation and gelatinase activity. So these gelatinases are things that can break down the extracellular matrix or the kind of supporting structures around the blood vessels, as well as affect the collagen within the blood vessels. And this is an older study from 2015, which looked at this in mice and found that giving mice minocycline actually decreased the rates of bleeding in those mice. And recently from our center, we did a retrospective analysis to look to see whether any of our patients that we had tried minocycline in, whether that seemed to be effective. And this is just a retrospective, so not a randomized clinical trial by any means, but we did show that it was safe and tolerated in patients with CAA. And there was some suggestion of potential benefit where patients were having lower rates of larger hemorrhages in the brain after receiving that minocycline than they were before receiving it. There's been an ongoing study to look at this medication specifically. It's called the Batman study. It's being run by a group in the Netherlands in Leiden, and they enrolled patients with sporadic CAA and also patients with that hereditary form of CAA mentioned by Gargi earlier called Dutch type CAA in the Netherlands, and they received 3 months of either minocycline or placebo. And the recruitment for that study is completed and the results are pending. So we're all very excited to hear whether that's effective. The main things they're looking at is whether patients had additional bleeding events and also looking at inflammatory markers as well. We can also think about other places to intervene along this sequence of events. So thinking earlier, we can think about decreasing production. So sort of stopping this entire chain before it has the ability to cause damage to the blood vessels. And so I wanted to talk about a new study that's very exciting in the field of a drug called ALN-APP. And so this is an ongoing phase 2 study called Capricorn-1, which is a study in patients with cerebral amyloid angiopathy being run by Alnylam Pharmaceuticals. I just wanted to mention that I am a site PI at MGH for this study, but I have no other relationship with Alnylam. ALN-APP, it's an RNA interference drug that's been designed to decrease the production of amyloid precursor protein in the brain, so act earlier in that process. It's also called mivelsiran. And this trial is a randomized, double-blind, placebo-controlled trial, and they are actively enrolling patients with sporadic CAA as well as that hereditary form Dutch-type CAA. And the goal is to recruit 200 total patients for this study. And it's a multi-center study with sites across the US as well as internationally. So it's an RNA interference drug, and I know that many aren't familiar with that. So what is RNA interference? So essentially, if you think back to kind of high school biology, when you have a gene expressed, first your DNA is transcribed into mRNA. Then that mRNA is translated to form a protein. And RNA interference is a naturally occurring process in which that gene expression is regulated through interfering with that translation of mRNA. This was discovered in 1998 by Andrew Fire and Craig Mello, who later won the Nobel Prize for this work. And what they found is that double-stranded RNA strands can regulate gene activity by controlling degradation of mRNA. And this is how this works. So you have double-stranded RNA, which binds to a protein complex called dicer, and that cleaves that double-stranded RNA into these smaller parts. Those fragments then bind to another protein complex called the RNA-induced silencing complexes. And then that eliminates one of the RNA strands, and then the other kind of searches for a complementary mRNA molecule. When it finds that, it can then cleave that mRNA and break that down, and then you've effectively silenced that mRNA, so you're not going to get the protein from that mRNA. The way that Alnylam is using this technology is they've developed small interfering RNAs. And so these are kind of, you can think of them as the pre-cleaved double-stranded RNA that I mentioned before. And the idea is they are able to pass into cells. They then again enter that RNA-induced silencing complex and unzip. Then they complementarily pair to a target mRNA, and then you get that cleavage and degradation of your target mRNA. A non-trivial part of this process is getting this siRNA into the cells. And for this specific drug and some of their others, they've developed a small 16-carbon molecule chain that attaches to this siRNA, and that makes it more able to cross that cell membrane. It makes it lipophilic. And so the way that the idea of this study is that if we think back to that process that I mentioned earlier, you have your APP gene expression, you got APP mRNA, and then that typically is then translated to form the full-length APP protein. That's then cleaved to form amyloid beta, and then that's when we start to see these issues in CAA, where we start to see that accumulation around these blood vessels. Where ALN-APP acts is up here, so it acts really at that kind of getting rid of this mRNA here and preventing that full-length protein from being translated. So this, as I've mentioned a couple times, the study is actively enrolling. If you want more information, this is a website for the study. I've also put a QR code here that you can scan to also get to that website for more information. So I hope I've kind of talked you through a few things and a few exciting potential treatments on both sides of this spectrum. So we talked about ALN-APP, which acts to really decrease production in the brain, and then minocycline, which is acting all the way at the other end, trying to decrease blood vessel damage. There's a lot of active research and a lot of excitement about all of these different steps in between and potential other treatments on the horizon. And I just want to say thank you all for your attention, and I'm looking forward to the discussion.
Thank you so much. That was really interesting. Yeah, I'm familiar with the mRNA drugs. Well, I think we all know about COVID, and we hear that term a lot due to the COVID drugs as well. And then I know in systemic amyloidosis, we see drugs working that way too. So but it's always exciting to hear. And now if we can have our panel, Eric Smith, Susanne, Dr. Greenberg, Dr. Banerjee, Mariel, and we'll, before we tackle any of the questions, do you have any comments to make about any of the presentations or anything you'd like to clarify or anything at all? No, okay. So let's get to the questions, okay? Okay, let's see. Okay, are there any, all right, the trial that you were just referring to, Dr. Kozberg, here's a question. Are there any upcoming trials and treatments in the UK?
Yeah, so as I mentioned, that study is an international study, and I do think that they are planning for sites over there. I don't have an official site list, but I believe that is one of the areas. I don't know if Gargi can talk to the UK specifically.
Yeah, so that's my understanding too. I don't think the UK is actively recruiting as a site yet, but I think the plan is for there to be a site certainly at UCL, and I think people are working on getting that up and running.
Well, let me ask you, where is the trial actually recruiting right now besides Massachusetts?
So I don't have the most up-to-date list, but I know that the sites that have opened first have been in Canada so far, and then we have some in the US as well. We are going to be opening soon for enrollment at MGH, but have not yet.
Okay, so if anyone is interested, goes to clinicaltrials.gov, which is the site we always refer people to, clinicaltrials.gov, and then they put in their search terms, which would be cerebral amyloid angiopathy, and then they would see all the clinical trials for CAA pop up, one would hope, right? And then they would also put in what would be the name of the drug that they would put in to find out this particular trial that we were talking about?
Right. So the drug is ALN-APP or mivelsiran, and the study name is Capricorn 1. So they could find that, search for that as well.
Yeah,
or go to that study.
I'm sorry, I was just going to say, I'm also just entering into the chat. I think for all participants, the website that's been set up by the sponsor that allows, it gives some very good information and also allows people to put their name down, and you have to kind of find the drop-down menu for the Capricorn 1 study. So that's another way to go on the radar screen of the recruiting of the sponsor of the study.
So what would be that site? What would be the?
I just put it into the chat, so it's the tricky part. It's an easy web address, except it's an intentional misspelling of the word Capricorn because they wanted APP, the amyloid precursor protein, in it. So if people can see the chat, it's
Okay,
I did it right.
Okay, I'm going to share my screen here for a second, okay? Okay, so I've shared my screen so you can all see it, right? So I went to capricorn1.com with 2 P's, right? And this is the site you were talking about. So if people are interested, they can go to capricorn1.com with 2 P's, and that way they can find that out. Okay.
Muriel, I can tell you that in Canada, the only site that is currently actively recruiting is in Toronto. But in Calgary, we hope to become a site soon as well, just like Mass General. So we hope by, say, March of 2025, then Calgary would be the second site in Canada.
That would be great. Okay. Now, does it make sense to get coagulation blood draws? No, there are various ones. So does certain ones make the most sense?
Maybe we all sort of we talk to each other so much that I think we mostly have come to similar conclusions about a lot of the sort of patient questions that come up. So I think I'll be answering for most people on the panel, but please correct me if I say anything wrong. Most of the people who have bleeding from CA have completely normal blood clotting systems. It's true that if you put a stress on the blood clotting system using a blood thinner, that increases the chances of bleeding, and that represents a substantial share. But we don't think there's anything wrong with the blood clotting of most of the people who have bleeding from CA. It's because the blood vessel is broken open. It's not because the blood isn't coagulating the way it should. So we don't in general, we don't incorporate extra blood clotting tests unless we have some other reason to think that there's a blood clotting disorder. People have bleeding in other places in the body. And I'll always ask my patients, so are you somebody who bruises exceptionally easily, or do you get blood in your urine or blood in your stool, other evidence of internal bleeding? And for most people, there's no evidence that they have any kind of blood clotting disorder.
Okay.
Yeah, I could just add to that, that there have been trials of agents to thicken the blood, to promote clotting. The problem in CA is there's a crack in the vessel wall, and a clot is kind of like the patch to patch over the crack. But the challenge, and this is mostly people are having like acute bleeding, like within hours after a bleed happens. The challenge is promoting clots could like plug other healthy arteries. So, there's some fear of risk of promoting a heart attack or an ischemic stroke, the kind of strokes caused by blockages in arteries. So other than people that are on blood thinners where the effect needs to be reversed, it doesn't appear that thickening the blood is a strategy that would help.
And I'll just mention, of course, yeah, it's a great point. I'll just mention when we use the term blood thinner or blood thickener, we don't actually, we're using it in a figurative way. There's nothing too thick or too thin about the blood. It's just the way we often refer to clotting. I've had patients say, "Oh, is my blood thick enough or something?" And it's again, it's this clotting system, this amazing system we have for being able to put a patch in when there's a crack in a blood vessel.
Great. I can see we've got a lot of questions that we're going to be getting through today, and we probably won't get to all of them. So I do want to say, though, that we will get every question answered, because I know all of these panelists' cell phone numbers and emails, and I have ways of making them talk. So I will make sure that we get answers from all of them, and we will email them to everyone. So you will have answers. So don't fret if you don't get your question answered today. Okay. Here's a suggestion for the next CAA conference that you have. You just had the one in Munich, so I don't know if you have your next one planned yet or not, but it says, could it be considered that at the next CAA conference, a patient could be present to explain from a patient's perspective, especially one that has been misdiagnosed and given blood thinners in error during a bleed? Maybe this could help ER docs understand how devastating this is. So who's going to be in charge of the next CAA conference?
I can let everyone, so the next conference will be in 2 years. So not in 2025, but in 2026. And it will be in Banff, Alberta, Canada. So that's in the mountains near Calgary. And one of our objectives is to enhance engagement of patients and people with lived experience with the International CAA Association. And we're thinking of ways to have a greater presence at the conference, maybe programming specifically for patients and people with lived experience. And if you answer the survey at the end of the webinar, there's an opportunity to volunteer to help us with this kind of thinking and planning. Susanne, did you want to add anything to that?
Yeah, thanks, Eric. I will say that we've had patient advocates be present at our meetings, especially this one at Munich. We've heard from representatives of the Dutch type CAA community in the Netherlands, and also previous conferences we've organized sort of a half-day patient forum, if you like, where we really try to create this interaction between physicians and scientists and patients and their representatives, and really to promote that interaction between these groups. So thank you for your suggestion, and I think we will definitely work on that moving forward.
Thank you. We know that the physicians that attend these conferences usually know more than the average physician that's out there. So do you do grand rounds for medical students or grand round for residents, so to help educate neurologists on what to do and what to look for, and maybe spread some awareness about the disease? Any of you?
I can start, and then maybe Steve and others can mention. Yeah, so for healthcare professionals, they often look to guidelines for how to provide care by consensus panels of experts, and that kind of consensus guidelines don't exist right now for CAA. There are CAA relevant guidance in bits and pieces across different other medical guidelines. So, for example, for how to care for someone with a hemorrhagic stroke, but not guidelines for CAA in one place. So this is one of the projects of the CAA Association that's ongoing right now, is to generate those guidelines, which would go on our website, which we disseminate, all the panelists here are always looking for opportunities to give grand rounds, to talk to other physicians and healthcare professionals in training to disseminate knowledge about how to best care for CAA.
Okay. Okay, well, we've had a couple of questions in regards to autoimmune diseases. So this particular one says, I had an inflammatory reaction to having CAA, and since then have not developed various autoimmune diseases, or have no developed various autoimmune diseases. How common is this finding? And what is the relationship? Is there any relationship between autoimmune diseases and CAA?
I have all have thoughts. Mariel, do you want to take a crack?
Sure, yeah, I can. So I think that this participant's referring to this condition in CAA that I think none of us mentioned in detail, which is CAA-related inflammation, which is a specific condition that can develop to CAA where you end up with what we call clinical inflammation. So inflammation in large areas of the brain looks actually similar to some of those amyloid-related imaging abnormalities that I mentioned before. There are not clear studies that show a link between having CAA-related inflammation and having other autoimmune conditions. So it's not uncommon for a patient to just experience CAA-related inflammation without having another autoimmune disease. There are certainly some situations where we see both, and potentially having autoimmune diseases predisposes you to these larger inflammation episodes, but it's not kind of a prerequisite to get those conditions. We've looked very carefully for CAA-related inflammation because we think of it as one of the more treatable things in CAA. We can treat it with steroids, and that's typically very effective. I don't know if Steve or anyone has something else to add to that.
Yeah. Maybe the only point I'll add is just as a general, this is a little broader than the question, but for the most part, everything in CAA happens in the brain. I think I saw also a question about other kinds of amyloids. And of course, we're speaking of the amyloid support group, where there are probably many people on the call know about or themselves are involved in one of the heart amyloids or nerve amyloids or other types. And those seem to be completely separate, even though that amyloid term sounds so much like the same thing, and that it's a source of confusion sometimes for patients, sometimes for doctors. And there may be some shared principles, but for the most part, everything in CAA happens in the brain, and everything in the other amyloid diseases happens outside the brain. So I think, I don't think there's been any large study of whether this autoimmune aspect is more general, but just going from my own patients, I don't know if other people feel like it doesn't seem to be. It's certainly not a pattern that stands out where people have multiple. So I think the answer to the question is, yeah, seems to be the rule, not the exception, not to have other kinds of inflammatory autoimmune conditions.
Okay. Is CAA with dementia comparable in symptoms and progression to dementia without CAA? Anyone?
That's a tricky question. I can say it's tricky as well as anybody else can. I think none of it. It's a difficult area. The reason I showed a little bit of that cognitive decline that's come out of the Rush Medical Center's studies. That we know that most people have multiple things going on in the brain when they lose their memory. It tends not to be a single thing. Alzheimer's disease is a huge part of why people lose their memory, but conditions of the blood vessels, including CAA and other kinds of degenerative conditions, often happen alongside Alzheimer's disease, or just on their own, or in combination with each other, not with Alzheimer's disease. So it's a really messy question, because there are so many combinations of diseases that can cause people to lose their memory as they get older, and it often is a combination. So nothing is pure anything. There's a little bit of a tendency in Alzheimer's disease for the short-term memory to be highly affected, so people can't remember some piece of information they just learned. That's a little less of the rule in people where it's the blood vessels, where it tends to be other things, things like we say processing speed, or which is just what it sounds like, how quickly the brain is able to do operations, or the thing, the executive function of being able to switch from topic to topic easily, to multitask. And that tends to be a little bit more part of the CAA and other blood vessel conditions causing memory loss. But those are very messy rules and often lots of overlap between one and the other. So for the most part, we can't really tell when we hear that someone's going downhill cognitively what the cause is, and we depend on different tests to try to tease apart, oh, it looks like there's an Alzheimer, it looks like there's a blood vessel coma, it looks like there are other things going on. So it's a difficult area, and patients often wonder, do I also have Alzheimer's? And a lot of times we can't easily tell. And for the most part, it doesn't change treatments, although as Mariel discussed, we are moving into an era where we do have at least some kind of disease-modifying treatment for Alzheimer's disease. Not as good as we want it to be, not as safe as we want it to be, but at least we are making progress. So there's a little bit more of a reason to try to diagnose Alzheimer's disease now.
Thank you. Some of these
Could I add
questions,
something to that, Mariel? I mean, I think that was a great
Absolutely,
response, Steve.
absolutely.
I would just add there can also be the effects of symptomatic strokes in CAA that also impact cognition, like from having a hemorrhage that injures part of the brain. And with stroke recovery, there can be some improvement in memory and cognition sometimes. So, but I agree with Steve. It's, as a clinician, I'm trying to listen to the story and look at the brain scans, particularly to discriminate kind of like three potential contributors: the effect of strokes, if there have been any, the effect of CAA on the brain. Dr. Greenberg's work and mine and others has shown that CAA interferes with the regulation of blood flow to the brain, and that seems to play a role in preventing people from remembering, concentrating, and thinking properly. And then Alzheimer's disease can be a fellow traveler, so that's sometimes hard to, that also has to be considered. So I'm trying to discriminate between these three different contributors, but it's challenging in an individual, and we're still looking for better markers of these processes. There are cognitive enhancing drugs, so these are not disease modifying drugs, but cognitive enhancing drugs for Alzheimer's that I would sometimes use in my practice if a person with CAA is experiencing like an ongoing progressive cognitive decline in the absence of having new strokes. So these are medications called the cholinesterase inhibitors, donepezil, which goes by brand name Aricept, and others is one example, and memantine. So sometimes those types of medications may be used to try to enhance cognition in someone with CAA and progressive cognitive impairments.
Oh, I have to ask now because you brought that up. What about Prevagen?
Yeah, I don't think good evidence that it does anything. It's interesting because it's a bestseller, and I think again, I think I'm speaking for everyone. We don't care where an effective treatment comes from. We don't have any. We don't care if it comes from a supplement store or from a pharma company. We just want effective treatments, and people use a lot of supplements that haven't gone through the same kinds of trial processes, such as the one for this Capricorn study, where it's very carefully tested against a placebo treatment and very careful measurements where nobody knows what the patient's actually getting to show whether something has a beneficial effect. And a lot of medicines, Prevagen, as far as I can tell, doesn't have any risk to it. I don't believe that it puts patients at risk, but I don't see. We all want something that will improve the memory, but I haven't seen that. Outside of the medicines that Eric mentioned and others, we just we don't have it yet, and until we do, I don't want to give people the idea that, oh yeah, there are all the supplements will protect the brain. We want them to, but I don't think we have evidence that they do.
Yeah, my approach would be similar to Steve. Like, we don't have the scientific certainty that I can recommend that all my patients should take it. But I think for people, but it seems very safe, right? And I think for people that are interested in kind of supplements for brain health, that would be like a reasonable one to choose.
Okay. And we've got so many questions to go through here. So, and some of these folks I want to tell you are a little personal and you're looking for second opinions, and I'm all for free second opinions. And we will present all these questions to our physicians for answers, but we won't do some of those personal ones here on the webinar. Okay, those will be done, after the webinar. Okay, can an abnormal work schedule, such as working night shifts for over 10 years, augment the effects of CAA long-term? Thoughts, opinions?
Sounds like one for Muriel or Susanne to me. I don't know. I don't want to put you on the spot. I can go too.
Yeah, I was thinking Susanne might be good. I can say briefly, I don't think that we have good data or things to really answer that question from clinical experiences, but I think Susanne might have some thoughts about sleep and how that plays into this as well.
Yeah, I don't think we have good evidence. I think in general, it's good to not work too hard. I think that's a general wisdom for everyone, also on this panel. But again, especially there's no data, I think, on working night shifts and how that sort of plays out over the long term. And there is some, as Mariel said, some studies looking at the effects of sleep and sleep disturbance on sort of the way the brain clears waste. And there's some evidence that especially during deep stages of sleep, the brain is particularly capable of removing waste during the night. But still, there are so many unknowns in that part. And so there's ongoing investigations to try to figure out how the brain does that and how we might be able to augment that to benefit those with CAA and other brain disorders, if that makes sense.
Okay. Can you associate headaches with the microbleeds in the brain?
I can go first if you want. Yeah, I don't think I've seen a correlation between the appearance of new microbleeds, the number of microbleeds, and the frequency or severity of headache. Headache is pretty common in the acute phase of having a brain hemorrhage, from CAA or from other causes too. It's often seen during the recovery as well, although I don't consider it a poor prognostic sign. So people do often ask about it, and sometimes we have to do a scan just to check, but often I can reassure them that the amount of headache is not a poor prognostic factor for future risk of hemorrhage and not a factor in the recovery. It may just be part of the recovery period. So, but I'm curious what the other docs here think about it.
Yeah, just to say the microbleeds are really micro. They're tell people they're smaller than the tip of your pen, and MRI again is amazingly sensitive to be able to see them, and they're very important markers for us to understand and make a diagnosis in people. But it's not clear that that they cause any symptoms at all. And patients will often say, "Wait, how could I have had these and not know about them?" And we know that that's true for many kinds of small brain injuries, and true for the clear majority of microbleeds is that they happen silently.
I know that Dr. Greenberg, you covered the heart healthy diet, just kind of a common sense diet for people. But this person wants to know, can a cleaner diet, and I don't know what that means, but you might, can a cleaner diet and normal daily sleep schedule reduce the effects of CAA? And is inflammation related in any way to the cause of CAA? So, but let's get to that cleaner diet first.
I think it's not a term that is used in sort of general medical discussion of nutrients. We don't talk about what's clean in the sense of uncontaminated. Yes, of course, is good for you. But yeah, I don't think it's a term. I don't know if it's a term that's used in to describe specific diets. But yeah, it's not one I'm familiar with.
Yeah, I do get questions from patients sometimes because I described it, the amyloid as a protein. So people ask about its relation to diet, and I reassure them that it's it's a protein made by the body, right? It's not like in the food. So although eating a healthful diet, is good for blood vessel health and therefore I think for CAA in general, but you don't have to worry about avoiding certain foods. I guess unfortunately you can't, avoid progression by avoiding certain foods either, right? But so following a healthy diet, you could look at, the Canada Food Guide, there's maybe some evidence that a more Mediterranean style diets may be healthier for the brain and the heart. So those would be the kind of suggestions I would give to people about diet.
Okay, is there a relationship? This person said dad has a type 1 diabetes for 57 years. Wow. Is it likely that there's some sort of relationship between diabetes and CAA?
Gargi, why don't we put you on the spot?
Yeah, so I would answer by saying not that we know of. As we've all said, I think at various points in the webinar, although we're not completely certain about what drives and causes CAA from the beginning, there's not really been a signal in the data that we have to date that suggests that diabetes is something that drives that. That being said, that we know that diabetes is important for brain health in other ways, and it can have an impact for other forms of stroke, particularly forms of strokes that are associated with clots. But for CAA, I would say that there's no relationship that we've observed so far. I don't know if anyone else wants to add to that.
Okay. Are white matter lesions in centrum, I don't know how to pronounce this word, semioval? You're nodding, Dr. Smith.
You got it, sure.
Okay, can we get that question answered?
I'm happy to take this one. You're right, it's centrum semiovalle, and that's sort of the larger part of the white matter in the brain, where all the connections are, and the sort of the highways of how the brain's network operates. And so there are often white matter lesions seen on MRI scans, also in patients with CAA, but it's not very specific for underlying CAA pathology. So we do see this in a number of other conditions, especially in the aging brain. And so even though a certain pattern of these white matter lesions has recently been added as supporting features to the updated clinical diagnostic criteria for CAA, it's not in itself specific enough to diagnose someone. So even though we do think it seems to contribute to the disease process, we still don't fully understand why they're there and how they come about. But we do see them. But again, it's not super specific for CAA, as we do see them in other types of brain diseases as well.
Okay. Are there altitude issues with CAA? And I don't know if they mean, like if they're like live in Denver versus living in Chicago, or whether they're concerned about flying, but maybe you could tackle both of those.
Yeah, not to my knowledge, so people do ask about flying, and if they've had a recent stroke, I prefer people to wait a few weeks or ideally at least a month, partly to make sure their mobility and tolerance for sitting for a long period is okay. I warn people that it's often dry on these flights, and it's important to stay well hydrated just for kind of general health. But there's it's safe to fly again after when having CAA or after having a stroke from CAA after some recovery period.
Okay. If you are a patient with CAA and require knee replacement surgery, are there alternative medications to blood thinners that you can take?
Yeah, comment. It's one of the thorny questions that comes up, and we're not the experts. For better or for worse, each of us takes care of just one part of you, and so we're the experts on brain stuff. And the people who do the knee replacements have become very good. They've a very strong incentive to prevent clotting after blood clots forming in the legs after a leg is immobilized because of a knee surgery. And so we often have discussions. I think I'm probably speaking for the people in the who practice in this field, that we often have discussions with the knee surgeons, and they say, what do I do? And we say, well, if the knee surgery is very important from a quality of life standpoint, go ahead and do it. And then just try to use the shortest and least intense course of blood thinning treatment afterwards that is still good enough to get the job done. And that's usually, people understand, there's kind of a range of going longer, going shorter, of how strong the anti-clotting treatment should be. So I think the person ultimately to weigh in on this is the surgeon performing the operation. They're the ones who have to be confident that it can be done safely without causing blood clots, but that we ask them when there's a range of options to go with the least intense and the shortest period. And it's clear the longer you treat with a blood thinner, the greater the chances are that something's going to go wrong. I hate to use the term, it's an awful metaphor, but of playing Russian roulette, that sort of each day you're on a blood thinner, there's a chance, it's probably a small chance that any bleeding will happen that day. But the shorter that period is, the safer it is. And many of my patients have been on blood thinners for periods of time and had no trouble at all. But I always kind of breathe a sigh of relief when the day comes when they're able to stop the blood thinner. And so anyway, it's a complicated question, as you can tell, with a lot of things weighing, but I don't recommend that people, when it's clear that getting a knee replacement will improve somebody's quality of life, I say go ahead and do it. It's the quality of life is obviously super important and needs to weigh very hard on the scale.
Okay. Oh, this is going to be a great one for me to pronounce. I know that the use of cadaver dura has been linked with iatrogenic CAA. Having had a couple of bone grafts for cervical fusion and dental implant, has there been any investigation in the possibility that bone graft may also be a source of iatrogenic CAA? What is iatrogenic CAA? And then you can answer the question.
I think Dr. Banerjee should answer this one.
I was going to say, shall I perhaps take this one?
Yes.
So iatrogenic CAA, the word iatrogenic means medically acquired. So when it comes to CAA, this is an incredibly rare form of CAA, and it's only kind of really been recognized quite recently. So we're learning more and more about it, but you know, it's something that we associate with very specific medical procedures, most of which haven't taken place for the last 30 or 40 years. So the person who asked the question mentioned cadaveric dura, that's one of the kind of materials that was used in some of the procedures for the cases that we've seen. But cadaveric dura is this particular form, certainly, for example, in the UK, hasn't been used since the early 1990s. And the reason for that is because of it was associated with other conditions, and so use of those products was stopped. So, as I say, the thinking is this is vanishingly rare, and it's associated with things that happened a long time ago. We don't have any strong reason to believe that there's ongoing risk at the moment with the medical procedures people are having. And I think the cadaveric products in particular, they were processed and collected in certain ways that I think or we think made the risk of CAA during that historical time period greater. So certainly, you know, things like dental implants, there's you know, there's no reason to think there's an association with CAA through that. In terms of bone implants, again, you know, to date, we don't have any reason to think that's associated with iatrogenic CAA. I think the key thing to remember about that particular form is that it really is something we associate with procedures that haven't taken place and don't take place anymore because of other public health reasons. Again, I don't know if anyone else wants to add anything to that.
Okay. If I have CAA, is there a protocol I would follow if I want to donate my brain after I die?
Susanne, do you want to weigh in? You've done such amazing work. Yeah.
Well, I think there are many opportunities on participating in brain donation, it's really just one of the most generous gifts one can make to research, because we learn so much from investigating and studying these brains after death. And so we highly encourage patients to participate. And often this can be done through a local autopsy service at a local hospital or a research center that is more specialized in these types of investigations. We out of Mass General have set up a brain donation program specifically for patients with CAA in the past. And we have sort of more recently limited this to patients who've participated in our ongoing research studies during life. But we do encourage folks to reach out if they have any questions about donating their brains, and we can help with resources and guidance as to finding a place also locally if someone is out of state to make that happen. Yeah, I think it's a great question.
Okay. Another tough one for me here. Okay. Is there any potentials for the delivery of VEGF-C, which I understand is very effective in increasing the waste removal from the brain using viral or mRNA technique? I'm lost on that question.
Mariel, do you want to take a stab at it?
Yeah, so I don't know much about, honestly, I'll be honest, I don't think I know much about that pathway being elucidated within the brain. So I don't know if others do, but I don't think that there's a lot of active research studies in this particular mechanism of trying to clear things from the brain. I don't know if others have knowledge on that.
Okay, well, let's try and do some research so we can get something answered on this for the future, okay? Okay, are there ways to prevent dementia with CAA-RI? I don't know what that is.
Yeah. Oh, so let me start at least. So yeah, CARI is an abbreviation. We use more of the foreign language training that you're getting, Muriel. So CAA dash related inflammation. So we'll often abbreviate it as CRI, and it's that form that I think Mariel spoke about, where the body generates its own immune attack. I always say it thinks that the amyloid is some kind of an infection, and that puts it in this broader group of autoimmune diseases, as we talked about. And we think that that's the form of CAA that we have the best treatment for. It's still often not easy to treat at all, but because there's so much has been learned about anti-inflammatory and immune suppressing treatments, and that's become a really specialized area, especially in neurology, for the range of autoimmune brain diseases. And we think we can quiet that down, and for many, maybe the majority of people with it, once it's quieted down, once the inflammation goes away, it stays away. For there's still a sizable number of people where it comes back and has to be treated again, maybe treated more aggressively. But we think people do okay with that CARI, and we're still learning a lot about it, whether that puts people at risk for dementia down the road. I don't think we have real strong evidence that it does. We know in general that advanced CAs we talked about can injure the brain, but the CARI part, as far as we know, doesn't lead people down the road to dementia, although again, we're still learning a lot, and I don't want to say we have certainty on it.
Okay.
Yeah, if I could make a comment too, I agree with everything you said, Steve. I think there's often some confusion that comes along with the presence of inflammation in the brain, like during an attack, and then with immunosuppressants, if they're successful in controlling the inflammation, then the confusion improves. Although in some of my patients, it doesn't improve all the way, I guess is what I've noticed. And then although often then it remains stable moving forward, unless there are repeated attacks. So as Dr. Greenberg mentioned, there can be relapses or recurrences, even many years later after the first attack. And I do wonder if there's been a relapse, whether chronic inflammatory treatment is needed, something used for other autoimmune diseases to suppress inflammation. Although this is one of the less common causes of, or one of the less common CA syndromes, and we don't have a lot of evidence on what the right approach is, but that is something I'm doing more often in my patients that have recurrences, because what I've seen in several patients with this condition is that cognitive impairment is driven by the relapses. And so if there's been a recurrence, then a focus on ways to prevent relapse might be one thing that should be looked into. Thanks.
Okay. Sherry says, we have read about previous studies with positive results of taxifolin. Do you have any information to share? Taxifolin, anyone? Okay, we'll have to say no.
Well, I mean, I think we're looking. I think we've all seen the reports, and it's to me, it's not at all convincing. I put it a little bit in that category when of kinds of supplements where again we want anything that works, but I think the evidence that it's beneficial is not strong, and in general we haven't. I don't want to speak for other clinicians, but I haven't been recommending it for patients. I just don't think there's enough evidence. Again, it falls in that category, seems to be safe, but I haven't seen good evidence that it's beneficial.
Okay, we're getting nods there. Okay. How is superficial siderosis related to CAA? My dad was recently diagnosed with both. Superficial siderosis, never heard of it, but I know you have heard of it.
Mariel?
Yeah, I can comment.
Okay,
So
yeah.
we do use sometimes confusing terms here. So I'll just maybe clarify. So there's a very rare neurological syndrome called superficial siderosis, where patients sort of build up blood products around the brain, typically kind of around the base of the brain, around the cerebellum. In CAA, we've kind of borrowed from that diagnosis, and we've developed this term called cortical superficial siderosis, where it's superficial siderosis actually involving kind of the cortex kind of surrounding the brain. I know Steve showed some pictures of that as well. And so that is one of the diagnostic criteria now for CAA, for probable CAA, as Steve mentioned earlier. So most likely having that term is probably referring most likely to cortical superficial siderosis, which is a common finding in patients with CAA. I don't know if Steve or Susanne has anything else they want to comment on, or anyone.
No? Okay.
No, I think, yeah, that's done.
Okay, now Jessica says her symptoms began after open heart surgery, and she wants to know what medical procedures were related to CAA. Are there any that are related to CAA?
So I think I sort of partly answered a related question earlier about sort of kind of iatrogenic CAA and medically acquired CAA, you know, as a very rare form that's really something we think about as being associated with sort of historical procedures, you know, several decades ago. In terms of kind of other procedures, you know, somebody else asked a question about knee surgery. So we know that when people have medical surgery, sometimes depending on the procedure, you might need to have additional treatments. Obviously, I don't know the specifics of this situation, but you know, sometimes for open heart surgery, you need to be on certain medications, or during the procedure itself, you might need to have certain medications administered, and sometimes some of those medications can increase the risk of bleeding. That doesn't mean that those procedures kind of cause the CAA. It's more that if you had CAA and then you know, for an unrelated reason, like a surgery, you had to have some other treatments that might increase your bleeding risk, that combination might result in kind of the CAA becoming diagnosed. But certainly not, you know, I don't think it would be correct to say that an open heart surgery would cause CAA. And again, I don't know if any of my fellow panelists want to add to that.
No, I think you're right. You know, sometimes CAA may be diagnosed around the time of a procedure, even though it didn't directly cause it. But for example, a procedure that requires large amounts of anticoagulant, like blood thinning medications, could provoke a hemorrhage. And then the workup for the cause of the hemorrhage could reveal that CAA was present, or confusion or other neurological symptoms around the time of the procedure might lead to a scan that identifies CAA as a contributor. So sometimes CAA can be unmasked by procedures, even if the procedure didn't directly cause the CAA itself.
Okay. Is hyperbaric oxygen therapy considered a therapy for CAA, or has it been considered? I just saw something on TV recently about PTSD being treated with hyperbaric oxygen.
Yeah, I think I'm the one who gets to throw buckets of cold water on all these really cool ideas, and so no evidence that it's beneficial, and no that I've seen, and not a strong theoretical reason to think so. That said, I have to say, we've learned so much about CAA, and there's still so many unanswered questions, and a lot of it's all of us are looking for new approaches, and we know we need better approaches than the ones we have now, and there aren't a lot of times easy ways to find out whether different things will work. People will try things, and it's understandable that people are looking just as we are for a disease modifying therapy. So a lot of these times where I say, well, there's no evidence, it doesn't mean it doesn't work. It just it means we don't have evidence, and in general, we try to prioritize the approaches that have the strongest scientific rationale. In other words, if you can make a really good connection, especially from animal studies or from our understanding of how CAA progresses, to say we think we're really blocking a particular pathway, we tend to give those highest priority. But I feel like we're going to just need to keep testing different well-designed approaches till we find one, or hopefully more than one, that will slow the disease down. So when I'm throwing buckets of cold water, it doesn't mean that none of these things can work. We don't know, but our goal is to test sort of the strongest candidates one by one until we find, we hope, a range of treatments that will slow the disease.
Okay. At what point should someone expect to hear back if they were selected to participate in the Capricorn trial at MGH?
I can talk to that. So we are, as I mentioned before, we're kind of in our opening stages of the trial. We're hoping to open within the next month or so, and then we will be reaching out to everyone. I know we have a long list of excited people. We really, really appreciate it. And so you'll be hearing from us soon, but probably not for the next couple months or so.
Okay. Question, what about steroid use? When and why would these be prescribed?
So I can talk to that again. I think that's also related to that CAA related inflammation that we've mentioned a few times. So that's specifically when people have these really syndromes where they come in with severe symptoms of inflammation, and that's headaches, seizures, severe cognitive decline that Dr. Smith and Dr. Greenberg mentioned before. And that would be the time in which we would consider doing steroids if the imaging is also consistent with this CAA related inflammation.
Okay. I have, oh God, idiopathic urticaria with angioedema for more than 30 years. Very random, although sometimes causes is known, like tight shoes. Zyrtec helps the swelling and itch to resolve in a couple of days. Doesn't happen very often anymore. Is this a type of inflammation and could it be happening in my brain?
Yeah, no reason to think so. That rule I said before is still the one that's most often true, which is that CAA is just a disease that happens in the brain, and the CAA-related inflammation just happens in the brain. So stuff around the rest of the body, again, the caveat that we're still learning stuff, but yeah, it's most likely unrelated and wouldn't do the same thing.
Okay, and you mentioned a Dutch version of CAA that's inherited, and this person wants to know, can CAA be inherited from parents? Are there other inherited versions besides it? Is it autosomal dominant? How is it inherited?
And perhaps I can, I think 'cause I mentioned it in my talk, perhaps I'll start with this and perhaps others can add. Dutch type CAA is one of the inherited forms. I think, again, just to speak generally, inherited forms of CAA are rare. As I mentioned in my presentation, the commonest types of CAA seem to happen without any clear cause. But there are these kind of unusual circumstances where there are particular families where CAA seems to run in the family. Dutch CAA is one of those gene changes that can cause this, but there are other rare forms. Most of the forms that we know about are autosomal dominant. I think that was asked in the question itself. But it tends to be, I think there's probably a handful of mutations that we associate, particularly with CAA, that's associated with bleeding in the brain, with brain hemorrhages in particular. I suppose the other things to say is that the gene, the APP gene, which we know is the one where you get the gene changes that are associated with CAA, changes in that gene can also sometimes be associated with Alzheimer's disease, and we know that there are familial forms of Alzheimer's disease that sometimes you can also see CAA in. But as on the whole, I say that it's a rare and unusual form, but there are forms other than the Dutch type. Again, I don't know if others want to add in.
We have a question about the Capricorn trial. They want to know how long it will last before it goes to a phase 3. So what are the outcomes that you'll be looking for so that it can move, and when do you expect to have that outcome so that it can move to a phase 3 trial?
I think we all have discussions, but I think it's no decisions and nothing that's publicly known as far as I know. So that the usual approach just for anybody developing a drug is in these phase 2 studies, which the Capricorn trial is one of, you're looking for some signal that you're on the right track and good reassurance that a treatment is safe and tolerable, meaning that people don't get the kind of side effects where they need to stop taking it. So those are the things you really need to know before making that decision of, yes, should we go ahead with a large, challenging, expensive phase 3 study to see whether it can be approved as a treatment. But I think there's just so much uncertainty. And look, we don't in the CA field, as is true in most of neurodegenerative disease, no treatment is disease-modifying treatment has reached that goal yet. Again, we've gotten there in Alzheimer's disease, but for most of the neurodegenerative field, that's a really high mountain to climb, and it hasn't been climbed yet. It's not been climbed yet in CA. We want to change that. We want to make treatments get all the way through that pathway. But anyway, it's a long way of saying we don't know, and will be really determined by what happens in the phase 2 study. And here this is no inside information. It's just that's really what any phase 2 study needs to do, is show safety, tolerability, and some hint that we're on the right track.
I'm going to share my screen for a second, okay? Okay, I'm in the clinical trial for the drug, and it says study completion estimate 2029. And then it says primary completion 2027. And then it started May 2024. But what I find with the study, it says it has 9 locations. Now I know that we expect to see more than that because it was mentioned about Calgary starting. But here it says Naples, Florida recruiting, but it doesn't say where in Naples, Florida. I'm sure there's, and then it gives Massachusetts locations, New York locations, but it doesn't give the center, it just gives the city. So that's not very helpful when patients are looking up this trial and they see Dallas, Texas, or Houston. Do you think they could clarify that and actually put the name down of the center that where it's happening?
Yeah, I mean, again, I don't want to speak for the sponsor of the study on Alum. I think this kind of feedback is super helpful, and so I think everything that you point out, Muriel, or that other people point out, will be taken seriously by the sponsor in trying to get this information available to people. Right now, if the good thing about signing up on that Capricorn One website is that puts you on a list to find out about availability closer to you. With any clinical trial, there's this period at the beginning where sites are going through the kind of approval process that Mariel described at Mass General Hospital, which is getting all of the logistics lined up to be able to do the study, getting all the approvals, the human studies and ethical approvals that Mass General Hospital and every hospital requires for every trial involving people, and certainly any that involve a treatment given to people. There are sort of a huge number of things that have to happen to make sure it's safe, that it's well thought through, that it's feasible, and that it's not too burdensome for people. And those approvals will be happening at every site that is considering participating as a site in the trial. So that list will grow, the specificity of it will grow over time, and the number of sites that are approved right now are quite small, but that will clearly go up as and this is happening where it won't just be one new site, it'll be many new sites will, again, I'm speaking here about any trial, will come online sort of in a hurry as these regulatory and review processes all move forward. I think
Great.
it's a long way of saying, yeah, hold on, stay tuned, and if you're interested, make your interest known, and people will be very happy to give you the information you need to make a decision about where you might participate and whether you want to participate.
Yeah.
Muriel, I was just looking at that capricorn1.com site, and it looks like clicking around on it that you can indicate interested in learning more and then submit a web form with your name and sort of approximate location, like country and zip or postal code. I presume the sponsor would get back to you then, but saying these are the sites that are nearest to you. So I hope I'm right about that. I don't know, but from looking there, it looks like that would be the best way to find more specificity around the exact location and contact information for a site.
That's true, and I think it's valid, but there are people that want to be anonymous when they go investigating these things, and I think if they can see where the center is, that will make them feel more comfortable. And rather than having to divulge information to a pharmaceutical company. No offense, I know Elm Island is a wonderful company. They're terrific. We love dealing with them with other types of amyloidosis, but still there are patients that are hesitant to do that, and we want so. It would be very helpful if we had a little bit more information on the clinicaltrials.gov site for them, so they could be a little bit more anonymous when they're searching. Just a few little FYIs from the patient perspective, I think.
Sure, yeah, or other companies. I get it too. I hate giving my email to anyone because I don't know who they're going to sell it to, or things will show up, right? So I don't like Dr. Kozberg, myself. Like we're in touch with a company, a site PI, so we'll give them that feedback. That's good feedback. Thanks.
Okay, and we do want to say, if your question wasn't answered, like I said, I'm going to submit all the questions to our panelists today, and we'll give them a week to answer them, because we know they do have other things they do, believe it or not, right? But with that said, I will be sending out an email to all the attendees, giving you information on where you can find many of the things that we discussed today. So don't worry if you weren't able to get to a certain link or things that were mentioned weren't quite clear to you. We'll make sure that you don't have any questions by the time this is done. Well, you'll still have questions, but we'll try and get as many as we can answered. We have about another 5 minutes, and I also want to say thank you so much to our panelists. How many diseases have doctors that are willing to give us their Saturdays, right? Not many, but in the amyloidosis world, we're unlucky in disease, but lucky with physicians, that's for sure. We call you amyloidologists in our world, and we really appreciate all of you giving us your time today. Well, let's see. Okay, does dementia happen for all CAA patients?
I can start with an answer to that. The answer is no. is that most of the patients who are diagnosed with CAA don't have dementia at the time of diagnosis. It is a risk condition for developing cognitive decline, and there is an increased risk for dementia compared to the general population, though. And you know, if all our patients with CAA live to be 150 years old, would they all eventually get dementia? I guess that's like not clear. But certainly I have patients diagnosed that have lived, you know, 10, 15, 20 years successfully without developing dementia. So I would not say it's inevitable. And you know, many of the things that we think promote brain health in general are probably healthy for the brain with CAA as well. So I saw some comments in the Q&A about, you know, diet, exercise, healthful sleep, cognitive, you know, engaging in cognitively stimulating activities, including social activities, maintaining your mental health. You know, these are many of the things that we can do that are helpful for everybody's brains, but also people with CAA.
Okay. We'll do two more, okay, and then we'll be on the hour. And again, we can't thank everyone enough here. Can we include ApoE genotype as a marker of CAA? Maybe next version of Boston criteria. Any update on interaction of ApoE and CAA?
You're on mute, Steve.
Sorry, I thought I had clicked it. I've now clicked it. Yes, so ApoE is a gene among all the genes that we all carry around, and it has different types, and was shown years ago that one of the types of ApoE predicted higher risk for Alzheimer's disease, and it's true in a slightly different variation that there is, it's a kind of risk factor for having CAA or having CAA-related bleeding. As long as ApoE has been around, there's still uncertainty about exactly how it does that. It's come up again in the Alzheimer treatment field because this ApoE type also puts people at higher risk for that kind of ARIA, that kind of antibody-related inflammation that Dr. Kozberg spoke about. The reason it's not part of the diagnostic criteria is it's not sensitive enough or specific enough, meaning that you can have CAA without having any of these ApoE risk factors, and you can have those risk factors without ever developing ApoE. So it doesn't add enough information. It has been proposed in some other kinds of diagnostic criteria. This one that Dr. Banerjee spoke about that came out of the Edinburgh group have proposed it. It's not clear even there how much the ApoE adds. So I think my practice is not to test ApoE genotype very much. And right now, I think most of the testing that's happening is happening for people getting that Alzheimer immunotherapy. But just because I don't think it has enough actionable information where it tells me who really has CAA. So people are very aware of it. It's been known for a long time, but it hasn't in general made its way into treatment and practice. At least that's true for me.
Hey, Karen says, I have recurring pneumonia and often have a heavy cough. I worry that with fragile blood vessels, this coughing might precipitate bleeding. Is there something I can do or take to minimize coughing? Over-the-counter prescription cough meds are not helping.
Maybe I'll just comment again. It's really intuitive to think that the blood vessels are somehow fragile, that you have a bunch of delicate glass blood vessels, and if you shake your head the wrong way or if you cough, you'll cause them to break. And that doesn't seem to be the case. Again, I always say the same thing. We're still learning things. And I don't want to say that we've got the last word, but maybe the best evidence we have for it is there's some people who have bleeding in the brain who require surgery to remove the blood. And we know that in certain circumstances that probably is beneficial for at least some patients. And the patients who have surgery done to remove the blood who have CA don't, you'd think, oh gosh, well, that's the worst thing you can do to blood vessels is actually start to do surgery on the brain. That must really cause them to bleed. And we know that's not the case, that people with CA don't do any worse with surgery in the brain. It's always a dangerous operation for anybody, but it's not any more dangerous for people with CA compared to everybody else from all the evidence we have. So it doesn't seem like the blood vessels are fragile to stuff that you do. And I always ask people what they're doing when they had their bleeding stroke, and it's usually watching TV, or they woke up with it, or they're just going for a walk or something. It's almost never when they're doing something that involved a vigorous activity of the head. So as far as we can tell right now, there's no danger to coughing vigorously or doing something else. You're not going to cause bleeding to happen by something you do.
Okay. Well, I want to remind everyone that there's a survey we want everyone to fill out when they leave our webinar. It will also be emailing you a copy of the survey if you didn't get a chance to fill it out. We want to thank all of our panelists today. We can't say enough wonderful things about all of you. I think everyone realizes now that they're in wonderful hands with this disease. So we thank you all so much, and we'll all be in touch about anything that might happen in the future. Okay. Thank you. Thank you. Thank you.